Welcome. I am Marcy Timmerman, Executive Director of Mental Health America of Kentucky, and you are participating today in our lunch presentation of What's the Data Say? Third quarter 2021 screenings data discussion. I do want this to be a discussion, so we will only be recording the beginning of the presentation, and then we will discuss data off record. And folks who are catching us later, feel free to participate in discussion with us via comments and other things like that. So just wanted to get that out of the way and let folks know when and how we'll do that. So digging in, who are we? In case you aren't familiar with MHA Kentucky, we were established in 1951 as a 501c3. We actually had some groups together before that. We used to be called Mental Health Association of Kentucky. That is still our formal name. We do business as Mental Health America of Kentucky. We are advocates who set up the conditions for the first Department of Mental Health in the USA to be established. That was right here in Kentucky. We were a leader in mental health back then. We are proponents of trauma-informed care and helped transform that process in Kentucky as well. And now we're providing education via mental health first aid, QPR, which is a suicide prevention program, self-care, boundary setting, grief, lots of other different topics that we've covered this year and last year. And we plan on doing more of that. And we've been doing that our whole history. But just to kind of give you a brief summary of things we've done recently. And then in advocacy in 2022, we're going to be working on Fund 988 Kentucky, and I'll be happy to answer questions about that. Ban conversion therapy, we're going to be tracking bills that are related to mental health and substance use and more in 2022. So you'll hear a lot from us on our advocacy front. And then with research, we review the latest research, we get the latest information to patients and families in the Commonwealth, trying to help speed up that process of best practices to actual bedside, or in our case, usually often telehealth or meeting side, right? Conversations. So who am I? I am the executive director. I've been the executive director here since April of 2017. It's coming up on 5 years. Woohoo. I have a Master of Health Administration from the College of Public Health at the University of Kentucky. I also have a bachelor's in English. I am a mom to Will, who is 7 years old and may appear because he is here today. He is homesick, and wife to David, if folks know my husband. Lexington resident for 15 years, and I've been a mental health advocate pretty much since I stepped into Kentucky. I was one before I got here. So of note, I want to make sure that folks know I am not a data scientist, so I will not be able to answer highly technical questions, but I am happy to pass those on to our team at national, or even some local folks that have volunteered to help us kind of dig through this data in a more in-depth way. So what is this data and where is it coming from? It's a common question. When folks hear that we have data, they're like, what is it? Where does it come from? Well, mhascreening.com or .org. Actually, that should be .org. I have a typo. And our custom link is mhaky.org, mhascreenings.html. If you go there, you end up at the same screening. These screenings are hosted at MHA National's website. These are national screenings offered. So we have lots of different screenings, and I'll be happy to go through those in a moment of what ones exist, and we'll actually go to this website. But I want to make sure that folks know that this data is self-selected, right? Folks have chosen to go to the website, and from one way or another, any portal that they enter it through, they have chosen to take a screening. So these are not randomized controlled samples of any kind. The number of screenings are not necessarily the number of people either. A lot of people take different screenings, and we know that we do keep some IP address information should something happen. And so we have that, and we can check that and know that nationally. But all that data that we collect is de-identified, right? The IP address is not given to me. I do not get your name. We do not ask for anything other than hopefully you can give us some demographics just so we know who we're following. So I'm going to go ahead and go to the website and show folks what that looks like when you go there. Screen.org. And yes, like I said, it is .org, not .com. So I will fix that typo. But here are all of our different tests. We have depression. We have a new one, depression test for new and expecting parents. So if folks are interested in knowing more about the pregnancy process for both parents, or any parent actually, including adopting parents. So come on and take that test. There's an anxiety test, a psychosis test, bipolar, eating disorder. There's PTSD, addiction. We have parent tests for your child's mental health. So anyone who's under the age of 12, we send those parents to this test. And then we have a youth mental health test for those who are under, are in that range of usually 11 to 17, can take that one as well. We do have some in Spanish now. finally, our anxiety and depression are in Spanish. We have a workplace mental health survey. If folks are interested in that as well, we actually break that out into a workplace report on the annual basis. So this is where they are. And these tests are, click button, easy graphically designed tests, but they are actually from real things. So in this case, PrimeMD is the source for this, but all of these tests are actual clinical tools. So I want to make sure that folks understood that they are clinical tools, they are clinically valid, and we have validated them additionally as the test itself online has gone through a valid validation process at the national level with multiple types of providers, multiple researchers in these spaces. So I want to make sure folks know it's not just something we made up, right? This is not your average internet quiz, although it kind of looks like one, and that's intentional, right? So we want to make it as easy as possible for folks to take the test. So that is where it comes from. And let's see here. Feel free to add questions in the chat as well. I'll answer as I go. If there's something that comes up, I'm happy to do that, folks. So what does the data actually say? Some general pullouts that I was able to come up with are more people in Kentucky are evaluating their mental health. And I can tell you that in the past, prior to 2020, we had maybe 4,000 to 5,000 screens a year in Kentucky. In 2020, we were at 20,000. We are on our way to 24,000, maybe even 25,000 by the end of this year. So a lot more screening happening in Kentucky than has ever been happening before. A lot of the push for that has been our national presence, right? We were brought into a lot of national conversations, which is great. And MHA Kentucky's presence, right, in the media when people are having questions about mental health, especially related to COVID, to grief, to children. And then a lot of more advocacy happening in the mental health space since 2020 happened. So since COVID-19 primarily, but not wholly. So some of these conversations were happening at an increased rate prior to that. Our depression, anxiety, bipolar, and psychosis have all increased severity rates. So they're more severe when folks are taking the test. They're getting more severe responses than they ever did. And we have that nationally as a trend, and it definitely is taking place in Kentucky as well. We also know when we're looking at our data compared to other states' data, rural counties here are in more need of additional efforts to prevent suicide. We are getting a lot of rural Kentuckians who are staying positive for suicidality. And so they're getting sent to the crisis lines and such. And these, I've pointed out that these screenings also have DIY tools attached, as well as pop-up screens for if you say that you're suicidal, there's a screen to get you to crisis help that is available for you. Multiple different lines, multiple different ways. So we will talk about those if folks want me to talk more about what those look like. But the crisis line, the text line, all the things are there. So young people are using our online screenings and DIY tools, but they aren't the only ones. They are a significant portion though, and I want to bring attention when we get to that space for the 11 to 17-year-olds. That number is a kind of staggering to me, how many we have. And then there's a large number of people who are getting screened as having an illness, but who don't seek or receive mental health treatment. Maybe they've never received it before, they don't intend to, and they tell us so. So that's kind of an important piece as well, what that looks like for us as a state. I'm not sure that we really know how to help increase mental health and wellness if folks aren't willing to go get treatment, right? So this is what some of the data that I actually get looks like. And so this is the third quarter only. So this is only for June through September of this year. We had 6,332 screenings, hence the reason I say we're at 6,000 every quarter right now. So it's going to be a huge number. But as you'll see, depression is overwhelmingly the screening that folks take. I'm not sure why. I guess that's something that most folks are more comfortable with talking about, though, perhaps. That's just my speculation on that, though. And then bipolar comes in as a second. And that's interesting because a lot of times it's anxiety that is our second most common. But there's been a real increase in bipolar interest throughout Kentucky via the screening. So we're not sure why, and I'm trying to figure out why. But it's definitely an interesting point that we need to work more on education, right, about our anxiety, depression, and bipolar illness. Psychosis has been increasing, and it's been almost steady the last 2 quarters at 10% of our screenings. And I find that also a little bit weird, right? Psychosis is not something I expect people to take a lot of testing on. I'm glad that folks are doing that. And we're not really sure where that's coming from either. So we're not sure if like a clinic is doing some more of these screenings and having everyone take them. That might be an increase for that. But it is interesting. And the severity of psychosis has remained steady actually through 2020 and 2021 within about a 0.5 point percentage. So, but yeah, this is kind of what it looks like for the third quarter only. And then we have our 2021 data so far. So we're over 17,000 screenings already. And see that bipolar and anxiety come neck and neck right there. So definitely some places that we're going to do some more education and reach out to folks and keep pushing out those tools to help yourself, especially since a lot of these folks are not going to be getting treatment, right? So we want to make sure that they are comfortable and hopefully introduce them to the comfort zone of treatment if they need it. So. And then this is our 2020 to the third quarter of 2021 data together. So 33,000 screens. We still have depression, anxiety, bipolar by far being the most popular. Our alcohol substance use is starting to go up, which I'm glad to see because we do have an increase in overdoses here in Kentucky that have become fatal in the last quarter. So we want to make sure that we're getting folks into the treatment that they need. And one of the resources under that is our Find Help Now KY.org, which is a wonderful source. If some folks don't have it, we'll have to go through that later. So the information we also get is how many folks are moderate to severe in the test and how many are negative or minimal to mild. And the reason these different words are in there, like minimal to mild, some of the tests have minimal, some of them will have mild. So they kind of lump them together based on, pretty good information. So this is the third quarter only. It was at 78.5% basically who are positive or moderate to severe. So that's a lot of people taking our tests that are that way. And it gets bigger. If we look through the whole year, it's 79.18. And it pretty much stays at that number, right? 2020 through third quarter. So that's a big chunk of the Pac-Man, as I call these things. So I find it interesting that a lot of folks don't come to us until they are severe. We would love to see negative or minimal to mild increase so that folks are checking symptoms on a more regular basis. So that is something we'll be doing some advocacy and education on. We do say it's a checkup, a checkup from the neck up, right, for our mental health screenings, and we want folks to feel comfortable taking them even when they feel well. So that is something that we will be working on at MHA Kentucky. So in 2020, in about the second quarter of 2020, we realized very quickly that we were going to have to start asking questions about what has sent people to us. We allowed people to choose up to 3. This is a voluntary kind of demographic aspect. So not every person who takes a screening will answer these questions, and not everyone will answer these questions every time they take a screening, right? So just so you know, in case the numbers don't add up in your head, that's true. They don't, but they could also choose up to 3. So there's a lot of variation, but it is concerning to us, but also not new to us that loneliness or social isolation are big problems that folks are having right now, especially when you're seeing our depression screenings, our bipolar screenings, and our anxiety screenings so high. That is not unusual to see loneliness and social isolation. So what are we doing to fix that? That is something we need to ask as a state. That's something that we need to ask ourselves as an organization. How can we help this? There is a national resource that we just rolled out called I Am Not Alone. And I will take us there in a little bit to look at that website, but it's a place where folks can go and learn about support groups that are open to anyone in the country. So free events, free classes, free cooking classes, and things like that can also be shared on it, which is great. Past trauma also brings people to us significantly. And I think that's interesting because PTSD screening is not one of our top 3, right? But trauma leads into all of those things. So it's very interesting to me that we have a lot of those folks answering that question. Relationship problems. Folks are having problems not just with their significant other, but also maybe as a caregiver to a patient. So I find it interesting that racism is really low, but I think when we look at our race stuff, that's because a lot of white people are the ones taking the questions. So we are trying to figure out how many of our Black, Brown, Asian folks are taking this who are saying racism. We want to know more about that statistic individually. So I've asked National to take a look at that because I don't have access to the data at that level. But yeah, grief or loss is also a growing concern in Kentucky. And I don't think that's that's surprising to anyone, that we are losing people to COVID-19. We're losing people to OD, right? We're losing people to suicide. So grief and loss happen all the time prior to the pandemic, but I think these seem amplified, especially if you're in a lonely situation and have some past trauma. That grief or loss can be even amplified even more right now. Other answers they could have are financial problems, current events like the news. So we often tell people to turn off the news or limit their news to a certain amount of time a day, set boundaries on their social media intake, things like that. That seems to be helping this number. And then coronavirus itself can send people to us. And I find it interesting that fewer people think that other than the other things. It's kind of an interesting statistic in Kentucky. I think other places coronavirus tends to be much higher. So here's our race and ethnicity. Sorry. There we go. For 2020 through the third quarter. So I wanted to show kind of who's taking these tests. 80% of them are white folks, which is not unusual because Kentucky is very white. And so this actually fairly reasonably reflects the demographics of our state. But we have had an increase in folks in the Black community and some more Asian community. And honestly, all of our diversity questions seem to be answered at an increasing rate, which is great. Some of the reasons that they may not be as many people choosing this demographic data as we would hope, because this is voluntary, they don't have to answer this part with their screening. We are hoping that more of these folks feel comfortable giving us that information in the future, because a lot of folks do opt out of it. So this wouldn't be every single test that we have. I want to make sure that's clear. So folks can opt out, they don't have to do this. And a lot of our Black, Brown, Asian, other diverse folks, our Middle Eastern, Hispanic folks, and our Indigenous peoples don't feel comfortable saying they are who they are, which is fine. I get it. I'm hoping over time we can win that trust. And so, but our income information I think is interesting as well. We have an overwhelming number of students. So our income being under 40,000, pretty common, being our common denominator is not unusual. Mm-hmm. Yeah, it was an interesting rate. So in our third quarter only, we had a little bit of a dip in numbers, but they've been pretty consistent throughout. So I wanted to make sure folks saw that. Our age range, though, I find this one fascinating. So yeah, under the age of 24, significant number of screenings, right? We've got between the two of them over 50% of our screenings. 0.5% includes 4 to 10. I had someone the age of 4 take the test in theory. So I'm assuming it was a parent for a child, but it's a very interesting test. So that's the 0.5 is like 2 or 3 tests that were taken. But it's still important to know. I mean, as young as 10, I had someone take a test too. So we don't know who that someone was, right? I don't get the demographic data correlation with that person. And that's good because we want to make sure we can't find someone, right? That's not the point of the anonymous online stuff. So I won't be able to see data related to that person, but I will say one person at age 10 also took some of these tests, clearly, at least one. So it's interesting, the 11 to 24 age range is where we tend to see mental health issues crop up more commonly. So it's interesting to me that the screenings level kind of reflects that. But also we're finding that folks under the age of 24 have a lot less stigma around mental health, a lot less concern about actually finding out if they have something and getting it treated if they do, which is wonderful. Unfortunately, we also know from outside data from SAMHSA that more than half of our youth are still not receiving any kind of mental health treatment in Kentucky, even when they test really high on something like our depression screening. So their test is a little bit different, but when they are showing that they have a major depressive episode, more than half of youth in Kentucky are not getting treatment. So we got to work on that. We did pass some laws in 2019 that made things a lot easier for us to have in-school treatment and telehealth options in the school as well. So hopefully those will increase some of our capacity to see those kids in the future. I will say it's also interesting, the 25 to 34 set, right, is also a pretty significant chunk of the test. And we're hoping to reach more of these folks as they age and make sure that we're not getting severity rates that are really high. Also wanted to share the gender information. So we are overwhelmingly female with testing. at 66%. That's not unusual. Women tend to be the first adopters, right, of mental health issues, healthcare in general, right? They tend to be the common folks who will test. But our increase of male and other, so non-binary, trans, any of those options, all of those folks has been increasing over the years. And I think that's really important. The bigger that gets toward 50-50, the better for us as a concept. So, and I'm proud of the other being growing number. It used to be around 1% would choose our other options, all the other options together. Sorry, this is not an other option. It is several options that they lump into other for this graph purpose. But we have increased that quite a bit. Our transgender number has been increasing as well. So we are finding ourselves in those spaces more often, more commonly, and I think that's good. I think that shows that we are becoming a more trusted source of information. And as we gain ground in those areas, hopefully we'll be able to connect with the actual individuals and find out what their needs are a little bit more specifically than the screenings tell us. So one big thing that we have done nationally, they are actually putting all of this data into a database soon that will be publicly available with suppression of 5 or less. So if there are 5 people in a county that take 5 screenings in a county and only 5, we're not giving that data out, right? So it's this very stripped down data that you see here. If people have answered age, race, then they're in there, but not by depression screening age and race, right? So there's going to be some limitations to that data. But what they've done is actually looked at Kentucky versus other states and Kentucky counties via population level versus other states. 3 of our counties are in the top 20 of small and mid-sized counties for severe depression. We've got Carroll County, which is number 1 in the nation for severe depression screening severity. We have Whitley County at number 9 and Martin County at number 12. We have also for suicidal ideation, thing I talked about a little bit earlier, Carroll County is number 2 in the nation from our small and mid-sized counties. Whitley again appears. So Carroll and Whitley have appeared in both, right? At number 4 in this one. And Anderson County is number 12. So these are folks who have taken the screening and have had suicidal ideation as a positive. The one above it is those who are positive for severe depression. So just breaking that down shows me that we need to throw more resources at all of our more rural counties, right? All of these counties are rural. We have given this data to Carroll County and Whitley County folks to let them know and to work on some advocacy at the state and local level there too. So anyway, that was kind of a peek behind the scenes at our data. I hope that was helpful to folks. And if there's questions, I'll be happy to answer them. I am going to go ahead and stop the recording.